how did you go from being a practicing psychiatrist to thinking about rapamycin? Like, how did those worlds connect?
Well, I could kind of break that into two ways, I think. So you and I first met about 10 years ago when I had just seen a talk from Martin Scharf at the Karolinska Institute showing that in bipolar patients, if you're on lithium, your telomeres were longer after 6 months. And they were longer actually than your unaffected relatives. And I saw that talk and I was like, oh, this is a huge opportunity because now we have a biomarker of aging that is easy to get. And maybe we could use this biomarker to revitalize the use of lithium because lithium's a generic drug and no one's making money off of it. And yet the data now is unequivocal that lithium prevents Alzheimer's. And we have some of that. The Brazilians did a double-blind study on this 2 or 3 years ago. And we have some data now in our own clinic using the serum biomarkers that are commercially available that we can see reductions in tau and amyloid fragments in the serum within 3 to 6 months. And so I knew you were working in the aging community. And so I don't exactly remember my thought process. I was like, oh, I got to get somebody else involved in this because this is a way for us to leave the pharmaceutical world, which is all based in branded products, and just come up with a credible model for patients in the community who are worried about their risk of premature dementia to actually know that it's working, right? They take lithium, they look at their telomeres, they see that they're longer, and now maybe they have confidence that they're not getting pulled into the latest hype. And you were the person working in the area, and I don't exactly remember my thought process on that.
Yeah.
Right. And of course, neither you or I were in a position at the time to think about being a Sam Walton, which is, a brilliant skill set, to scale up a finding in biology and make it available in an inexpensive way to anybody in Washington State, the country, the world, in a credible way that's believable and that people can take a lot of confidence in.
So do you think that the data on lithium has held up over time? Like, you're convinced that this is a effective therapeutic for Alzheimer's disease and dementia more broadly speaking?
Oh, there's zero. I mean, there's nothing certain in biology, right? But every different venue that you look at lithium in terms of lifespan extension, there's no breaks in the data. If you look at random variation of lithium in the water supply, people live longer with higher dosages and they have fewer suicide attempts. If you look at the UK Biobank, looking at individuals that are on lithium for mood disorder versus individuals that aren't on lithium for mood disorder, the decrease in mortality is like 70%. It's almost unbelievable. Like a 70% reduction in point mortality per year on lithium. If you look at Drosophila, when you add lithium to rapamycin, you get an additive 15 to 20% increase in lifespan. It's orthogonal to rapamycin, right? If you look at the randomized trial that the Brazilians did for people with mild cognitive impairment, 2-year study, they saw an absence of progression of mild cognitive impairment and decreased CSF markers of tau and amyloid. If you look at our own data, which is really new, but N equals 1, N equals 1. For the people that tolerate lithium that we see that have early Alzheimer's, defined by statistical elevations of amyloid, tau, and neurofilament light in their blood, you can show reductions within 3 to 6 months with lithium. Okay. Now, the downside from this is that only certain people tolerate lithium well.
Hmm.
And what's the right dose? And there's an ecological reason that only psychiatrists prescribe lithium. No other medical specialty is familiar with it. Nobody wants anything to do with it because, maybe as a rough estimate, 30% of the population doesn't feel very good with a standard dose of lithium, implying that there's very subtle issues with patient selection and dose finding that need to be done. And of course, since it's a generic drug,
Yeah.
no one cares. Right. And so, to some degree, there's a lot of interest in rapamycin, but I would lay down the marker that lithium has actually got better data in humans, than.
Certainly more data.
No, well, I'm not saying effect size.
Yeah.
I'm talking about actual real world human data. The lithium data is unequivocal. And, and to give you an idea just how good this data is, if you look in these obscure public health journals, you'll find people writing stuff like, we think we should put lithium in the water supply. And we'll try to do that through a democratic process. But if the people don't agree, we'll figure out another way to do it. So, even the public health guys are kind of on this, that it's a really useful drug.
And what do you think the biological mechanisms are
For lithium?
Yeah.
Well, the dogma is that lithium's a glycogen synthase kinase inhibitor. And of course, that's dogma based from, 30, 40 years ago, and that's based on the technology of the time. And I'm not in a position to really drive down into that area. If you look at white blood cells in individuals who respond to lithium for bipolar disorder, you'll see upregulation of BICL2, which is one of the anti-apoptotic proteins for the mitochondria.
Right.
You'll see lots of changes in glutamine processing, which is really interesting because we know that cells require glutamine when they're growing as an alternate, as a way to replenish the citric acid cycle. And to a certain extent, the cell can't grow very well when it's in a glycolytic state unless it has some glutamine available. And that's really deep cancer metabolism, growth metabolism. I mean, there are whole careers based on this issue of glutamine processing, which is really, again, a lovely counterpoint to all of the discussions we have with type 2 diabetes, where it's all about converting fat into sugars and sugars into fat. And we just kind of forget the whole issue of like, hey, nitrogen's kind of important in biological systems. The reason humans don't starve to death is we invented a way of fixing ammonia, and our entire human society is based on cheap nitrogen, allowing us to not starve to death.
Right.
Yeah.
So, in your practice, you've got patients on lithium,
Yes.
and you're basing, some of this on your experience with these individuals. Now, are you measuring biomarkers in these people?
Are you talking about the lithium patients?
Yeah.
For most of my career, I mean, lithium was a drug for patients with mood instability.
Right.
And we use the term bipolar disorder, but it's really, I think, overwhelming to people because you have all these criteria. And, really, the concept of bipolar disorder is the experience of autonomous mood instability. My moods change from weeks, months to years without really clear environmental causes. I don't know why I keep getting recurrent depressions. I don't know why I keep getting recurrent episodes of agitation. That's bipolar disorder. And lithium was discovered really on accident in the 60s. And it's a generic drug, right? So even though it's considered the gold standard for bipolar disorder, as the years go by, fewer and fewer psychiatrists are using it.
How many people, roughly, I mean, ballpark, because I know very little about lithium, how many people in the United States are on lithium?
I have no idea.
I mean, are we talking hundreds of thousands,
Oh,
millions?
probably in the million.
Okay.
Millions, probably. And when it works well, it's an unbelievable drug. I mean, you'll see people who you just don't see them again. They've had a lifetime of mood swings and suicidal thinking.
Yeah.
And you find lithium, and now you see them every couple of years. You wave at them.
Yeah.
How are you doing? Great. It's curative.
I guess what I'm wondering is if it really has such a large impact on sort of overall health or biological aging, and that many people are taking it, why don't we know that already? Like, why isn't this widely known if that's the case?
Oh, it's a lovely comment, isn't it? It probably doesn't have a lot to do with what we think of as the principal component of aging, which is the carbohydrate to fat nutrient switching program. Type 2 diabetes.
And so meaning lithium doesn't seem to impact that sort of metabolic dyshomeostasis.
I don't think so. In fact, I'm almost certain it doesn't.
Which is
so that's what we focus on. Yeah. We focus on diet and exercise, carbohydrate restriction, caloric restriction, and we don't focus about this other very subtle issue of nitrogen signaling and stem cell maintenance. So there's lots of sort of hypotheses about how lithium might work.
Sure.
That it may be related to stem cell maintenance of the microglia in the brain. That's not a bad hypothesis.
Right? Yeah, which is, I mean, again, it's interesting because, I think it is very likely that the most predominant problem we've got in the United States right now is the metabolic component, right? In terms of what is causing most people to get chronic
but
disease.
In England, the number one cause of death is now Alzheimer's.
Is that right?
That's what I read it. I mean, who knows whether that's true? Huh. But it will soon. It will
it's
switch.
Number 6 in the U.S. right now.
I think it will switch.
Yeah.
Right. I mean, cardiovascular risk is dropping largely because of smoking reduction.
Still number 1 though.
Right. But smoking made a big difference. Right. And there's a gradual cultural shift to like, oh, okay, I get it. Metabolic syndrome's
important. So do you not buy into the idea that dementia and Alzheimer's disease is a metabolic disease?
I kind of think there's 2 pieces of evidence that are worth thinking about. And again, I don't know how well I can validate the data. But neurons are post-mitotic, right? And they've got high constitutive levels of P10. Right? They're designed to not pay attention to insulin other than during adolescence, right? I mean, what you see clinically is that the brain of someone who's got anorexia nervosa is still working, even though they're starving. Karen Carpenter's still playing her guitar and singing beautifully. And someone who's morbidly obese often is not necessarily depressed or hypomanic, right? So the brain, by definition, is designed to be insensitive to insulin signaling. I think that's a useful concept. It may not be true. Okay, other than adolescence.
Yeah.
Now, adolescence, yeah. I mean, that's a big deal, right?
Yeah.
That's why our humans have a delayed adolescence. That's not a trivial intellectual question.
Yeah.
There is some data from Taiwan that triple therapy with metformin, pioglitazone, and Actose is associated with a 70% reduction in Alzheimer's risk. I mean, but it's not randomized.
Yeah.
Right? And confounding by indication is everywhere in medicine. In other words, people are very health conscious, they really want to live forever, are different people than
Sure.
people that aren't.
Sure. Of course. Yeah.
Yeah. Well, it's not, I mean, for you, it's obvious because you're scientifically trained. But in clinical medicine, our people are coming out of medical school and they don't see this.
Yeah. Right.
Yeah.
Fair.
Yeah.
So, I mean, I guess the way, and again, it's speculative outside my direct area of expertise, but I guess the way I think about it is it's clear that being diabetic or having metabolic dyshomeostasis increases your risk for a bunch of different types of dementia. So there's a connection there. Is it causal? I don't know.
Well, bad
But-
tissue's bad tissue, right?
Sure. And I think there's reason to believe that being diabetic or metabolically compromised does to some extent accelerate biological aging. So I think there's a connection, but I think it is likely the case that there are many people with dementia who their dementia was not related to any sort of metabolic dyshomeostasis. And I guess what I'm just wondering is if it is the case that lithium is broadly protective against dementia, but not through a metabolic mechanism, is it going to be specifically in the people whose dementia is not related to metabolic dyshomeostasis? Or, like you said, are they sort of orthogonal potentially, and you are going to get benefit, broadly speaking, across all the different flavors of dementia or Alzheimer's
Right.
disease?
I'm trying to break this.
It's all speculation at this point.
Well, it isn't, right? Which is that maybe another intellectual experiment is to think of something like this group of people that I'm intensely interested in, which is obese without diabetes.
Right.
Right. I mean, people that are huge, right? But their fat cells are unbelievably healthy.
And usually they don't have a high proportion of visceral fat, right?
Yeah, that's an interesting issue as well, right? So, but they have an exuberant lipodystrophy where they make a lot of fat and they pack excess calories away beautifully without metabolic.
Well, as Peter Attia would say, they've got a big bathtub.
Right, exactly. But what do they die of?
Yeah, it's a good question. I don't know the answer to that. That's an interesting question.
That's an important question.
Yeah.
Right? Do they die of cancer? Probably.
Right.
Right.
Higher growth signals.
Do they die of dementia? I bet you they do. Right.
That's an answerable question.
Right.
We should know the answer.
We should know this. I mean,
maybe we'll see if we can figure it out.
It's shocking to think how much money and intellectual effort we've invested into the metabolic syndrome, and no one has looked at the anti-metabolic syndrome.
Yeah. Although, again, maybe you know the answer to this. I've wondered, but have never looked it up. Like, what proportion of people who would be clinically defined as obese do not have any evidence of metabolic dysfunction? Is it I'm assuming it's a minority, but I don't know, is it a small minority or a large minority of people that fall into that category?
Yeah, I'm kind of dodging the question, but I'm throwing this out there for people who are listening. In biology, it's a trivial problem. It's amateurish to show there's a connection between any process or signal to any signal of interest. It's the Kevin Bacon phenomenon. Everything is always connected to everything else.
Sure.
Right? It's the size of the effect that matters. Right? Now, is it likely that if you have severe metabolic syndrome, you're going to have microvascular atherosclerotic changes? Of course. Of course. Right? Is that going to accelerate an underlying unrelated dementia? Of course.
Sure.
Right? And so when you do autopsy data and you're looking at people who die of dementia, you don't see these pure cases. Oh, this is just Alzheimer's. A lot of times you see mixed cases.
Sure.
You'll see amyloid plaques and tangles, and then you'll see a lot of microvascular disease at the same time. So it's if we're going to slow down aging, we're going to need cocktails. It's not going to be one drug. It's going to be a cocktail that's right for you. And this is a really daunting task.
I half agree. I think if we're going to effectively slow down aging, we're going to need to hit multiple targets for sure.
We're going to hit multiple targets.
Yeah.
Right. I remember, so most people I see don't have genetic defects. I mean, they don't have early onset disease where they die at age 5. But the people that I see have normal genes and they have an imbalanced hand. Where genetics gave them too many spades, relative to how many diamonds and clubs and hearts they need. in order to survive in our current ecological
Right.
environment.
And I think that current part is really important and interesting because the environment has changed so much over the
Yeah.
last 30 years. Especially, I mean, again, this may not be obvious to everyone listening, but food is part of the environment, right? And that's a big way the environment has changed for most people in the past 30, 40
and
years.
activity.
Right? And activity.
Sure.
Yes.
I mean, people don't
Yeah.
move anymore.
Right.
Right.
So it's a very different, the genes that may have been, appropriate for the environment 30 years ago, the genetic makeup could be very different than the genetic makeup that's appropriate for the environment today.
Of course this is true, right? Yeah.
So it's complicated. But this is one of the limitations to looking at epidemiological data that's been collected over 30 years is if the environment's fundamentally different, the same correlations may or may not actually still apply today, right, as they did.
Yeah, I mean, epidemiological data is less and less interest to me these days. I mean, I think what you've been doing your whole career is saying, look, I got to look at the source code.
Yeah, which is why I immediately went to, do you know the mechanism for lithium? So let's go back to lithium for a second, and then we can continue to do this sort of this wandering. So, I mean, I guess the question in my mind is, obviously there needs to be some further evaluation of lithium to generate widespread. You're very confident to generate that sort of level of widespread confidence about lithium.
Yes.
What needs to happen? So if you were the czar of all research funding, like what would be the study to do to really demonstrate that lithium has these broad benefits, or who are the people who are likely to benefit from lithium?
Well, I mean, I think again, it's a question of what is an adequate amount of data. And the adequate amount of data, in my experience, working with normal people, is they have to see a blood test that tells them that they have a genuine risk of Alzheimer. Okay. And they have to have a response to lithium that shows that their risk is lower.
And so what would that look like?
This is exactly the same metaphor that we see every day in primary care. You go in, you got a big belly, one of your parents has got type 2 diabetes, you get your laboratory work, your glucose is marginal, your triglyceride to HDL ratio is elevated, and you got a high insulin level. Your doctor says, hey, look, it's coming. Train's coming, right? You can be hungry. You can exercise more. You can take semaglutide, right? But you got to do something.
Yeah.
Right? And most patients look at the data and it's a moment of mortality. Nobody's happy about going to their doctor. I mean, this is so important to teach medical students. You're not your patient's friend. They're not happy to see you. They would prefer to not be in your office, right?
I think we need to change that, but that's a whole different conversation.
No, but it's important, right? Yeah. And so people get this unfortunate smack in the face, which is, oh my gosh, I need to take care of this, right?
Yes. Hopefully they get that message and they do something about it.
Right. And so now there's a new tool that's out, which is looking at a statistical estimate of how much amyloid is leaking into the blood, how much tau is leaking into the blood, how much neurofilament light is leaking into the blood. It's produced now by LabCorp, a highly reputable company. Medicare pays for it, okay? And you can get a very physiological estimate of what's going in your brain. What is the three-dimensional space that your brain is aging in, right? So we're not just interested in Alzheimer's.
Yeah.
Right? We're interested in an imbalanced profile. What if one of these markers is super high and you have something like Lewy body disease?
Yeah.
Right? What if it's just neurofilament light? Well, is that something like MS or post-traumatic brain injury?
Do you remember the name of this test?
Yeah, it's called ATN.
Okay.
Yeah, and it's been studied in research setting for 10 years,
Mhm.
right? So everyone knows about it, right? But by the time you go to a neurologist and you show shrinkage in the temporal lobes, or by the time you're showing, memory loss, it's too late. You've already got cell death,
Right.
right? So now there's a position where people can say, oh, look, I have a biomarker of my risk. It's not perfect, right? But it's better than nothing.
Is the measurement of this test within the reference range useful for predicting risk? In other words, even if you're normal, can you tell the difference between good normal and bad normal? Or do we know enough at this point?
This is one of these things where, as a practicing clinician, you hit this point and you go, I get it. Everybody has a different referral bias. Everybody has a different way of interpreting their data.
Sure.
You got to just go in there and get your hands dirty.
Well, speculating, I guess.
Right. No, I get it. I get
Yeah.
it. So I have right now about 150 people that we've done this test on. Okay. We actually have some of your old students, some of your old medical students who used to work in your lab.
Yeah.
They've migrated over to my clinical
Good.
setting, right? And
Yeah.
they're doing some of the analysis, and
Yeah.
we hopefully will have a paper out on archives,
Great.
by October, maybe
Great.
November, where we can start to talk about what do we see in a community psychiatric clinic rather than a standard, sort of community survey
Yeah.
or specialized neurology clinic.
Yep.
And what does the distribution look like?
Yeah, this will be super interesting. And I mean, this is one of the great things of being CEO of a company like Optispan is like just talking with you here, I'm immediately thinking to myself, well, we're just going to add this biomarker to our panel. We're already doing comprehensive blood work.
Yeah.
Right?
I mean,
and we'll get data on people who are, participants in our Trailblazer program and people who are participants in our corporate benefits program.
yes.
Just regular people with a whole bunch of regular issues. And let's see what it looks like.
Absolutely. So let's say you're 60 years old, right? And you get one of these tests and it comes back normal. And you're like, oh, great, I'm normal, right? But you're in the upper 90%.
That's what I was going to say. That's what I was asking.
Yeah, you're in the upper 90 percentile, right?
Right. And we see this with inflammatory markers, right?
And I think this is really a very subtle point, which is the Alzheimer's and Lewy body disease process starts 30 years before you get memory impairment, right? The prodrome for Alzheimer's is anxiety. This has been shown for decades, right? So there's been these garbage epidemiological studies saying, oh, benzodiazepines cause Alzheimer's. And of course, it's all confounding by indication,
sure.
Right? That we have people who they're in their 60s, they're normal people, and they start getting anxious, right? And it's only 10, 15 years down the line that they start getting the memory impairment. And it's looking now, some of the Toronto guys are showing this, that a variable phenotypic expression of Alzheimer's is actually depression.
Sure.
So you can have Alzheimer's and the presentation is depression rather than actually memory impairment.
Right.
Right. So I think it's highly likely that by using these markers as a measure of brain aging, we're going to be able to help people be so much happier and so much more productive in their 60s and 70s, even in their late 50s. Because ideally, you want to not be in the upper 90 percentile.
So let me just make sure I understand these markers correctly. So what are they actually measuring at a molecular?
So I'm going to work my way through them. Okay. So they look at the ratio of amyloid, full amyloid to a fragment of amyloid.
Okay, got it.
And oh gosh, this is hard. You know what this is, but the mitochondrial associated membrane complex is where the mitochondria docks in the endoplasmic reticulum to get spare parts. Right. So if you're working your nerve cells really hard and they're just sending out a ton of energy, the mitochondria are going to wear out. So you can either make new mitochondria, grow them from de novo, okay, or the mitochondria can dock at the endoplasmic reticulum and get new parts from where new proteins and lipids are synthesized, right? So the definitive gene for early Alzheimer's is the presenilins, which is related to the amyloid protein at the mitochondrial associated membrane complex. So we're looking at mitochondrial repair in the brain when we look at amyloid leaking out into the blood. That seems pretty straightforward intellectually. I don't think there's a lot of concern that this isn't a reasonable, valid biomarker.
And is this all brain derived?
I don't know.
Okay.
I don't know. But, again, if we're looking at source code as biologists rather than in the silos, the way a lot of clinical medicine is, we don't care. If the MAM is abnormal, it's abnormal.
Yes.
So there is actually a muscle form of Alzheimer's disease.
That's what I was getting at, is you could actually have muscle degeneration, which is potentially going to present differently clinically with the same biomarker. You're right. In a sense, if something's wrong, you want to know something's wrong and fix it optimally.
Right. I mean, the difference, of course, is that the muscles burn fatty acids and the brain burns, preprocessed glucose at rates 3 times higher than a marathon runner. I mean, the brain is a stinking fuel hog, right? Like beyond belief.
Yeah.
Right. So you and Peter talk about maximal exercise, components, and I get it, but, and I'm like, hold my beer, Peter. I mean, this is, my brain's really cooking right now.
Yeah.
Yeah. So that's the amyloid, is the MAM.
Okay.
Okay. Tau, I don't think, again, I haven't had time to really look into this. It's a microtubule component. What I think would be very interesting is there is some data that it binds to S6 kinase. In other words, the tau is part of the circuit breaker on a cell that's sick.
Yeah, you're right. This is where we get into what you were talking about before, which is that you can find connections if you look for them, though. So the question is that biologically relevant or not? I don't know, and maybe, but people tend to look for stuff like that, and you can connect Tor to anything.
Yes, exactly.
Right.
So tau, I don't have a good pathophysiology
but this test measures both the fragment of amyloid compared to full-length amyloid,
right,
and tau.
And tau is clearly elevated in,
this is
in Lewy body disease.
Yeah, this is a little bit in the weeds. Do you know if this is a tau abundance or tau phosphorylation?
You're looking at the phosphorylation of tau.
Okay.
I forget which one. I think
I'll
118.
We'll put it in the show notes. I'll do a deep dive on this test.
Yeah.
This is super interesting, though. So
yeah,
in theory, this is a biomarker. I mean, I guess in more than theory. If it's offered by LabCorp, it's been clinically validated, used a bunch. Right.
I think everybody goes, there's something here.
So the question still, though, in my mind, and maybe we don't know the answer, but we've already speculated, is even within the normal reference range, potentially this is a biomarker that you can use to identify kind of where the trajectory you might be on.
Yes,
and
absolutely
validate interventions, lithium, maybe other stuff, as to whether or not they are moving the biomarker in the right direction.
Yep. I mean, you look at this, I think an average person would say, I get it. I don't want to be here.
Yeah.
Right.
Yeah. And this goes up with age. We know that?
Yes.
Okay.
Yes. So what we're seeing in our clinic with tau, which we think is super interesting, is when we did our first small sample, it was like 30% of people had elevations of tau. I'm thinking, what is that? That's referral bias, right? This is clearly referral bias.
Yeah.
And then there's a paper just came out in neurology.
And by elevations, you mean outside the reference range?
Outside the 5% reference range.
Got it.
Right. And it's like, that's really important. This is what we want to publish.
Actually, this is a point, though, that maybe it's worth just explicitly mentioning, because a lot of times these reference ranges are not built on clinical information, symptoms. Like you said, 95% reference range. All that means is you're in the top 5% of the population.
Right.
And it may or may not have anything to do with anything important other than you're an outlier.
This is the dirty secret in a lot of biological medicine. The reference range is Matt Kaberline's graduate students.
Right.
That's kind of how it's done some of the times.
Yeah.
Right. They're not that reliable. Right.
And right, and their population measurements, and the population may or may not actually be the same as the population as a whole. So that's one thing to appreciate. But I think also oftentimes the reference ranges don't track with any sort of disease risk, right? For lack of saying it. Most of the time they do. This is interesting. I don't know if you saw this paper, but we did work with Sue and Lee, who's a just amazing computer science professor at the University of Washington, where her graduate student, Wei, looked at all of the NHANES data and all of the features that are measured as part of NHANES. So blood work, measurements of arm circumference, socioeconomic status, all the stuff that's measured in NHANES, and just asked, can we create a biological aging clock and which features are most relevant? And she was able to do that, not surprising. But then she was able to look at these blood-based biomarkers and say, for each individual, we can assess to what extent is this particular marker predicting mortality.
Right.
And then look across the population. And for most of them, the mortality risk lined up pretty well with the reference ranges, meaning once you got outside the reference range, mortality went up on both ends. But for some of them, it only went up on one end, and it kept getting better on the other end. Right? Because these reference ranges were built off of a normal distribution, not applying it all to what that actually means to health. And at one end of the distribution, things just keep getting better. So you're referenced as abnormal, even though your mortality risk just keeps getting lower in that abnormal range.
Oh, yeah.
Right?
Yeah,
so this is just important for people to appreciate. Reference ranges usually are relevant for something to do with health, but not always. And they're sort of built off of population averages in most cases, not based off of what it means for your risk of dying or developing a certain disease.
Right, and we can talk about the concept of dementia, that it's a two-hit model, and we can probably get to that if we have time, because it'll fit very clearly into this whole rapamycin ketamine thing that I want to talk about.
Which we got to talk about, because that's super interesting.
We got to talk about that.
So anyways, so the question I asked, which you sort of dodged, sort of answered, is what would the study be that you would do with lithium? But I think so tell me if I'm understanding where you're going, which is that one thing you could measure is this biomarker, this blood-based biomarker in people, and you would expect to see it changed by lithium in the responders. Is that
we already have.
Okay, so you've got that data in your patient.
Yeah, it's a very small population, because I haven't had time. But, realistically, how in the world would you expect a biomarker to get 50% better with age? It's pretty strong.
Yeah, that's interesting. So, and this data is not published yet, is there?
No.
Okay, so that's something else you're going to have to
We're going to work on it, right? Yeah, we got too much work. So, so tau is this marker of Lewy body disease, and we saw a 30% prevalence in our population. And then the neurology literature came out with elevations of TNF-alpha in the CSF of individuals with elevated tau. And it also correlated with chronic pain. And then when we did our, dirty, just sort of correlational analysis, we saw that our patients on opioids tended to have elevated taus. And it sort of the piece came together, that there's a group of people that, and it's very common, this is a common aging phenotype, pain correlates with age, right?
Yes.
And is the person that's in pain and having fatigue and fluency latency as distinct from episodic memory loss, are they on a tau trajectory rather than an Alzheimer's trajectory? That's very testable, and we'll have that data within 6 months to a year. And we probably already have it now. We're going to present that at the Gerontology Society,
which is in Seattle this year.
Which is in Seattle, as long as they take our late abstract. So we're waiting on it.
I'm not high up in GSA anymore, so I can't pull any strings.
I got it, but we'll have it at the aging meeting in Anchorage. One way or the other.
That'll be a great meeting. Actually, I'm looking forward to that.
Yeah. And then NFL is neurofilament light is just a fragment of axons that's digested. And that has definitely peripheral components. I mean, so I had someone with shingles, her NFL was really high, and then of course it went away. Right. So and I don't think I've done as much of a deep dive into that area. So going back to the lithium issue, I think really what's going to happen is the market will simply happen. We'll have enough people that listen to this podcast, or we'll have enough people I literally had a referral from someone who was listening to one of my patients talk in a coffee shop.
Yeah.
and they heard that their doctor was doing this test, and they made an appointment because, a relative had Alzheimer's, and that's how it happened. I don't think we need the FDA to fund it. I don't think we need any grant organization to fund it. This is just private industry. Someone's going to find a $20 bill on the ground and pick it up, and it'll happen.
Yeah, maybe. I don't know. I mean, I like your optimism. I have a hard time buying into that, just having seen what I've seen, or at least in terms of like, will these things happen quickly? Will the larger community ever buy in with that sort of?
The neurology community is going to fight it tooth and nail. I mean, if you look at the way that they make these recommendations for evaluating, ATN, I mean, it's not all of them. But, you need to have a specialty neurology clinic with neuropsychiatric testing and brain scans. And
that's the reactive disease care community, right? Pushing back, which I get. But I guess what I'm wondering is, is there a way to accelerate these kinds of hypotheses where there's a high likelihood of success to actually generate a data set that will move the needle in terms of broader perception? Now, it's going to be hard to convince the hardcore reactive disease care folks to do anything proactive. I get that. But
I think
there are a lot of folks who are persuadable with quality data.
I think you already have the nucleus, right? There's a whole group of people out there who are very educated and flexible thinkers and are getting a partial response to RAPA.
Yeah, this is another interesting question.
And you simply bootstrap on that community. You show them the Drosophila data, which is it's orthogonal. And there's some primate data too that says lithium is orthogonal to RAPA. There's no question about that.
Do you have any data in your patients with this specific set of biomarkers that we were talking about on rapamycin?
I haven't generated that yet.
Okay.
I mean, that's kind of ongoing. With lithium, I don't have to do very complicated informed consents.
Right.
It's standard of care. I'm a psychiatrist.
Right.
Nobody's going to yell at me. Oh, my psychiatrist put me on lithium. The outrage, right? It's just not going to happen.
Right.
Right. Whereas, my psychiatrist put me on RAPA. What's that?
Yeah.
He must be crazy.
Yeah. Yeah. Right? We'll talk about that.
And the informed consent is much more difficult.
Right. So before we get to rapamycin, with lithium, what are the downsides? Like, again, if you could, so what do we have to be worried about if, suddenly everybody potentially had access to lithium? Like, let's just say it wasn't an FDA regulated drug anymore. You could go to the grocery store and buy it. What would we be worried about?
People can buy it. They can get lithium over the counter.
Well, you can.
You can, but, you wouldn't know what's the effective. I mean, it's the dose finding that's
And is it different for each person?
Of course. I mean, biology is a smooth gradient.
I know you say that, but most medications are not dosed to individual dosing, right?
That's a mistake.
Well, I agree, but nonetheless, what I'm asking is, when this is prescribed to people, is it actually dosed to symptoms, or is there must be a sort of standard dose range that you start at?
This is a really beautiful comment. It's a beautiful comment, and it's got so much depth to it. Many medications that we use are fixed doses that we dose at the end of the sigmoid curve. You're crapping out the extra for the fishes. Right. Because
just because maybe not everybody gets, I think, what you're getting at, which is that, I think statins are a good example here, right?
Yeah.
Where there's a dose response. You look across an average population, and the dose response, you get a pretty effective dose at 1/10 of what's usually prescribed. So what's usually prescribed is like hammering as hard as you can until you get side effects. Right. And then instead of asking, where do you get the optimal effect for the thing that we're actually dosing for? And so when you talk about the end of the sigmoid curve, that's sort of the shape of this dose response curve. And what we often do is dose well outside of what would be the biggest bang for the buck. Maybe
right.
Way to say.
I think we're going to lose our audience, but we could try not to, right? Which is the concept of an optimization gradient. right? No drug is going to give you a perfect dose. There's always side effects.
There's always a trade-off.
There's always trade-offs, right? Always.
Yeah.
Right? And part of the problem in biology and clinical medicine is that our brains are so small, we can't, as a patient or as a physician, do a very good optimization trial.
And
because we can't
really
hold,
expensive.
we can't hold all the data in our head at one point, right? So lithium's been around since the 60s. We're looking at 60 years of lithium experience. And you and I are still having a discussion about dose finding with a generic drug. It's just a message to the public just how difficult the issue of dose finding is. It's not trivial.
Yeah, absolutely. And I think it's fair to say that the incentive structure in terms of the way drugs are approved by FDA runs against actually doing dose finding.
Yes, I would agree.
So that's also a reason why we don't have that data in most cases.
Right.
With lithium though, so yeah, right. So you can buy it as a supplement, right, over the counter. Is the dose different than what it gets prescribed at, or the formulation different, or is it just
it's just a metal ion, right?
I know. I know what lithium
doesn't
is.
matter what kind, lithium carbonate, lithium orotate.
I guess the question is, why do you need why does anybody need a prescription or get a prescription?
Oh gosh, I mean, again, super deep question. Why are medications prescription at all? Right.
Okay, now that's going to be a whole different conversation.
Right. No, I mean it's and it fits into the whole aging problem.
Okay, but I want to let's talk about that, but let's talk about lithium first, because I want to get to the crux of this.
Okay, so let's talk about the history of lithium, right? So Arif Khan runs Northwest Clinical Research. He's one of our experienced psychiatrists who's been involved with this since the beginning. He said in the beginning, the only drug we had was lithium. And so we dosed people at very high dosages, and they got side effects.
And what are the side effects at high doses?
Things like reversible kidney failure and headache and urinating too much and tremor and cognitive impairment. And people would have lithium levels of like 1 to 1.4, and they'd feel terrible, right? And so it got a bad reputation because that's all we had back in the early 60s, late 60s and early 70s, right? And then as more drugs became on board and psychiatrists became more familiar with the drug, the average dose of lithium for bipolar disorder is around 900 milligrams. Okay. In the Brazilian trial for Alzheimer's, with people that already had mild cognitive impairment, I mean, the horse had already left the barn a little bit, they were dosing around 600 milligrams, 450 milligrams, right? Which is still going to give you a lot of side effect in a substantial number of people in the population. Now, let's go the other direction. Let me finish, though, right? We actually have data that natural variations in the water supply over a lifetime are enough to lower your risk of Alzheimer's, right? So we have this beautiful sweet spot that has simply not been explored. There's almost no published data.
And what's the range of variation there in terms of if you were to make that relative to like a daily dose? The range in the water is 100-fold?
Oh, I don't know. I haven't looked into that.
Okay. I mean, it is important though, right? Because if we're talking about a very, very low dose, a microdose, so to speak, over years.
Right. No one has done these studies because there was no money and no one thought that it was worth doing. So let me finish up with this concept of how we bootstrap this. You're getting a cohort now of people who are very intelligent, very motivated. They're on rapamycin. They're getting a partial response. Are there a group of people out there that say, hey, yeah, I see the primate data. I see the Drosophila data. I want to add in a little bit lithium. Let's look at some biomarkers like, my sleep density. I could come up with 1 million of them for you if you and I sat down with time and you do a cost function.
Yeah.
Is it getting better or is it getting worse?
Sleep is interesting because if you're wearing something like this,
right,
you can actually quantify.
Yeah.
To the extent that this quantifies what you think it's quantifying.
I think if you looked at this data, if you did a deep dive and looked at the lithium rapamycin combination data, this is solid data. It's solid.
Or lithium by itself. I mean,
or lithium by itself. Yeah. Not everyone's going to tolerate rapa. I mean, that's another story, right? Not everyone's should be on rapa, right?
I agree. Yeah. Yeah.
Yeah.
So again, going back to the lithium though, I mean, I think of the side effects you listed, kidney damage is the one to me that stands out as potentially the most concerning. Is that something that you need to
That may be confounding by indication again.
Sure, absolutely.
Because when you look at large groups of bipolar patients, they have elevated rates of idiopathic kidney failure, and it's actually higher with alternative mood stabilizers.
Uh-huh. Okay.
So we do know that lithium in some people acutely stresses the kidneys. But in terms of actually causing kidney damage, the data is actually not as strong as is sort of authoritatively put in the textbooks.
Right. And we see this with other drugs. Rapamycin has a bad reputation because of the way it was first used
Right.
in organ transplant patients.
Right.
So I guess what I'm just wondering is how much of like if there are people listening and they're like, huh, I can go get lithium, I could take a low dose. Is kidney damage something that you would want to be aware of? Probably get tested if you were going to do that.
I think this is the standard. If you're going to take a drug, have a physician who can curate the data with you.
I don't disagree with that.
It doesn't mean that you have to, but just doing it on your own is pretty tough.
And yet people are doing that with over-the-counter supplements all the time, right? Just stacking this bullshit. And so, those are drugs too. They're just not regulated.
I get it. But again, I'm talking to the public. Look, it's been 60 years since lithium has been invented. Okay. For better or for worse, I'm one of the experts in this drug. And it's humbling, the complexity. Yeah. You don't want to try to do this on your own. It's just have someone to give you sage advice.
And who would they go to for that? Other than you?
Somebody who is interested in aging and has an open mind and is going to follow all the data that's coming out. And we're going to have a new generation of doctors. They're going to come out. They're going to get it. That they're not in the silos. I'm not a cardiologist. I'm not a pulmonologist. I'm not a nephrologist. I'm somebody who's interested in the mitochondrial associated membrane complex, S6 kinase, all of the source code issues that you and I are getting killed with, every day.
Yeah.
Right.
Okay. Super interesting. I'm going to have to do a deep dive myself on some of what we've talked about, but I'm really interested in this new biomarker that I should have known more about, but didn't. And I'm going to learn more about it. So that's cool.